Just going to take a little bit of, I always talk before the recording in progress voice comes over. Welcome everyone. We're just going to give everyone a couple of minutes to join the webinar. And then we can get started for our 2024 webinar series from Manna. We'll show my age here, and I was going to say it always feels like romper room when I start to see all of the names emerge and think, oh, there's lots of people that I recognise here. So welcome everybody. My name's Sarah Wayland. And I think we've got probably half of the attendees already here by now, so we might get started on the hour. So welcome. My name is Associate Professor Sarah Wayland. I am a Senior Research Fellow at the Manna Institute and also a proud member of the Faculty of Medicine and Health at the University of New England. You'll have to excuse my slowly easing into using words today. I'm actually on research sabbatical until July, which means that I don't exist solely 7 hours a day on Zoom. So my skills are a little bit rusty. It's been a couple of months. So welcome everyone to the fourth webinar for the Manna series, where we take a different focus each month of better understanding the ways in which regional, rural and remote mental health can be acknowledged and understood from a professional development perspective, but also from a community-based perspective. What I'd like to do before we begin today and before I introduce the people who are here who are going to be presenting and starting off some of the conversation, I might just ask people if they could mute their microphone just to make sure that any external noise isn't in the recording. Thank you. So I'd just like to start by doing an acknowledgement of country. And I'd like to really reflect on the fact that Manna Institute respectfully acknowledges the First Nations custodians of this continent and pays respect to elders past, present and emerging. We honour their rich and cultural heritage, beliefs and enduring relationship to the lands and communities in which we all live and learn and work. I'm coming to you from Darug-and-Guringai land in the northwest of Sydney. It's kind of the world's most humid day today, so I'd just like to make sure that you watch me slowly during the hour webinar where my hair begins to take on more of the space within the Zoom screen that we have today. So for those of you that are new to either coming along to our webinar series or new to understanding the work of the Manna Institute, an overview of Manna that's really important to provide people with is about its core focus on making sure that we equip communities to take ownership of the mental health and wellbeing of their members, that we think about ways in which we build capacity and implement targeted solutions for priority populations, as well as acknowledging that every person in our population is a priority in terms of their mental health and wellbeing. The Manna Institute is part of an initial 3-year strategy to improve mental health and wellbeing in rural, regional and remote Australia. The goal is to support meaningful research and to foster the development of the professional workforce and translate those research findings into practical place-based programs. A lot of the work that we do at Manna filters down to many of the academics that come and work for Manna in terms of their teaching and learning, as well as their research. Manna is a virtual institute. It brings together leading mental health researchers from 7 universities in the Regional University Network, or the RUN network, as we often refer to it, including Charles Sturt University, Central Queensland University, Federation University, Southern Cross University, the University of Southern Queensland, the University of the Sunshine Coast, and its lead institution, the University of New England. What collectively brings us all together at Manna is that we are experts who want to collaborate with industry and community partners. Our community partners at Manna are Everymind, LifeLine Direct, and the Australian National University Centre for Mental Health Research. Our goal is to tailor solutions specifically to the regions and regional Australia more broadly, making sure that we always challenge ourselves about not being metrocentric in terms of thinking about the ways in which we can better support individuals in their communities. Now, today's webinar looks at the role of online technology in mental health support. And anybody that works for a university will know that every other conversation is about AI at the moment and the ways in which we make sure that people's learnings can be critically analysed. That it's not just information that's fed to us, but information that we can engage with. But online technology is not new in the mental health support space. I've been a social worker for 25 years, and for the last 15 years, all of my research in the mental health and trauma space has often engaged in the ways in which we use those online technologies. In the early days, it was thinking about chat rooms and focus groups. It was about utilising Facebook and then Instagram and now TikTok. It's also about thinking about artificial intelligence, but it all comes down to the ways in which we consider how we can deliver mental health support that is going to be relevant for different groups who have different needs. So part of my, invitation today as you hear our guest speakers is to make sure that you set aside your fixed idea about what online technology might be and think about the ways in which it can value add from a mental health support perspective. We're really proud to have two speakers with us today, and we have one speaker that was unable to attend because of some geographic challenges of being in the United Arab Emirates and some time differences. But our two speakers who are with us today is, first of all, Josh Wiseman. Josh is the Head of Data and Insights at Batyr. And Josh is a passionate mental health senior manager who's excited about leveraging technology for sustainable change. Josh oversees the Data and Insights capacity team at Batyr and is focused on driving the organisation to make data-driven decisions internally and to capture the insights of young people to improve mental health services across the sector. I know as someone who's got a number of young children who live in my house who are actually related to me, so it's okay that they're here, who utilise some of those resources that are available from Batyr. And it's really about acknowledging the fact that a whole world exists in young people's phones and the ways in which they connect with that can better support their mental health and wellbeing. The projects that Josh works on are the National Review of Headspace with KPMG and Department of Health, the National Mental Health Framework for Universities with Origin, OurHerd, which is Batyr's digital storytelling platform. And then we've also got the wonderful Chief Research Officer from LifeLine Australia, Dr. Anna Brooks. Anna's an experienced research leader and communicator with a strong track record applying for evidence-based learnings in policy and service provision contexts. She's long been a champion of Manna and has collaborated both with myself and with Professor Miff Maple at UNE for a number of years in terms of better understanding the ways in which we deliver services and the ways in which those services can shape policy and program delivery in regional Australia. So the way that we're going to focus today is really just inviting first Josh to speak. Then I'm going to give a bit of an overview from Anwar's work that he has been working on from a machine learning perspective. And then we'll finish up with a conversation with Anna. Will then lead to some open conversation with the audience. And it's at that point where I will stop the recording so that we have an opportunity for us to all safely communicate with each other. So I'd now like to welcome Josh, and he's going to talk to us about his insights in terms of working with Batyr and online technology in mental health support. Thanks, Josh.
Thanks, Sarah. It's an absolute pleasure to be here today and share a little bit about the work that Batyr is doing in this space. It's a huge depth of things that we could talk about, so I'll try and keep it as brief as possible to open up for as many questions. So to understand Batyr's journey in the digital intervention space, it's really crucial to understand who we are as an organisation. For those of us who aren't familiar with Batyr's work, we've been around since about 2011, and we work in the early intervention and prevention space with young people in communities across Australia, predominantly the East Coast, but a lot in regional and remote New South Wales as well. We've got an evidence-based approach to early intervention and prevention, which is focused on mental health literacy training, peer-to-peer engagement, and contact-based stigma reduction interventions. The core way that we do this is by training young people who have their own lived experience of mental ill health, and then facilitating opportunities to take them back into community and share those stories with a facilitator pulling out key learnings and outcomes and strategies that that young person embarked on to navigate the tough times they went through or to continue to manage their mental health moving forward. We really focus on amplifying the voices of young people. And to date, we've reached over 400,000 young people across schools, universities, and communities. We've trained over 1,200 lived experience speakers through our bespoke free 2-day Being Heard workshop. And we've delivered almost 3,500 programs to communities. But a couple of years ago, where most of our work was happening in the room, in classrooms and community halls and rugby clubs across the country, we identified that there was a huge gap where young people were engaging in online environments. Research from the eSafety Commissioner's report showed that over 90% of young people use social media platforms. And other research in 2020 showed that there was almost 8 hours a day that young people between 16 and 24 years old were engaging with digital content. So there was a huge market where we weren't actually engaging young people in our positive evidence-based conversations about mental health. But as we are all familiar with, all the conversation and discourse that is dominated in this space is about the negative impacts of social media. And there's no denying that there are huge negative impacts of these platforms. But there's also evidence from young people's experiences of having these positive communities online or feeling less lonely. And with the loneliness pandemic that we're currently experiencing for young people, it's really important to question all we know and the common narrative we have about these online environments. In particular, there was research done a couple of years ago that showed that 81% of young people indicated that social media made them feel more connected to their peers and their social networks. And 68% said that they felt they could reach out to someone through social media when they were going through a tough time. So there's an opportunity with the high density of use of young people in these environments that we wanted to see if we could come up with something that actually met their needs. That's where Our Herd came about. So Our Herd is a digital storytelling platform we've been in production of since 2019 and about to release a new version of the platform. Essentially, we started this process to translate the peer-to-peer, safe, impactful storytelling that we do in the room into a digital environment to give young people access to these stories, these peer-to-peer stories, anytime, anywhere through their smartphone. But we didn't want to duplicate what already existed in the environments as well. But we did a landscape analysis of what was available on the App Store at the time when we started this project. And we found that there were no apps that were specifically aimed at improving mental health literacy or articulation. Only 4% of the apps available were actually targeted towards young people, and only 7% of wellbeing apps use some sort of peer support or social media platform. And more concerning was that less than 4% of wellbeing apps had any sort of evidence to support their claims. So we identified that this was an opportunity for us to leverage our expertise in storytelling and translate it to a digital space. But we didn't do it alone. We collaborated with young people, over 1,600 young people in developing the platform, over 70 mental health and digital experts from the sector, and reviewed over 180 academic articles on phenomenology to digital interventions to safety in terms of data tracking. So there's 3 audiences for Our Herd: story consumers and story creators and data consumers. The best way to understand what Our Herd is, and it's available on the App Store or Android as well, but essentially, the look and feel of the platform is something reminiscent of TikTok or Instagram. There's a story feed that young people can navigate through. But the core differences with Our Herd is that all the stories are shared through the lens of experiencing tough times with their mental health. And all stories are pre-moderated before they go live onto the platform. One of the major challenges with traditional social media is that there's a post-moderation process where something can be flagged as unsafe after it is already live. With our system, anyone who wants to share their story is taken through a bespoke flow where they learn to share their story safely. There's mental health education and literacy training to know how to share about particular topics in the safest way possible, and also frame their story in a way that has a positive impact on their own mental health, reflecting on the experience and that of the consumers who will be digesting that content. Our moderators on the back end, who are trained lived experience experts, work with those young people, and it's not just a no, that story is not allowed or it's unsafe. We'll work with them to get that story to a point where it is safe for an online audience. Users on the other end, on the front end, can search stories by topic. If they or a peer are going through a tough time with their mental health, they can search topics by diagnosed mental health issues or more psychosocial factors that they might be experiencing as well. The idea is that they can get access to the most peer relevant stories that they're going through and learn strategies from the young people who are sharing these safe stories about how to intervene in their own or their friends' lives before they get to the acute stage of needing intervention. The outcomes that we're trying to have is improved mental health literacy, earlier intervention, and less demand on the systems that are overwhelmed, particularly in regional communities. So the idea is keeping young people healthier and having an earlier intervention with practical strategies shared by other young people. But then we come to the data side of things, and this is where the opportunity of doing this in a digital landscape is really exciting. So on the back end, we essentially leverage both qual and quant data collection to look at trends within communities. All the stories are de-identified, but we run them through a thematic analysis to look at what are the common themes and trends within communities, and then also look at the user behavior. So the 3 data points that we use are the thematic analysis of the stories, the user behavior in terms of where are they spending most of their time engaging with content and accessing support directly through the platform, the insights that we're learning from the stories themselves, as well as validated surveys that we have inbuilt into the platform. What we're able to do with this then is pull out the data on the back end. And this is where we use AI and machine learning to access insights from the data, the completely de-identified data, and work with communities to identify the needs earlier. So in a school pilot that we ran last year with a year 9 and 10 cohort, we essentially gave them access to the platform for a 2-week period. And we were able to look at what were the trending topics within that community to identify to the school, completely identified at a cohort level, what was the trending topics. And we identified that around 10% of those students were looking at suicidal ideation and self-harm topics. Almost 40% were looking at gender identity and sexuality issues. And 20% were looking at other mental health issues specifically, with almost 10% looking at ADHD specifically as well. We were also able to identify through our validated surveys 20 students who were experiencing high levels of distress and work with the community to support them in that schooling environment. This is just the tip of the iceberg of how we can leverage the data that's captured through the platform at a de-identified level and completely transparent with our users to inform and amplify their voices to what is actually working within their communities and what isn't working within their communities. Happy to share more about it when we open up the discussion, but I'll leave it there for the sake of time.
Thanks, Josh. I've popped a few links in our chat and also said for people, if you've got questions that you'd like to ask Josh later when we get to the question time, you can pop them in there, because I know sometimes if I don't ask a question straight away, it's lost to the universe, never to be heard from again. So if you want to pop any questions there that you have, then we're happy to circle back around to those. Josh, I think it's really lovely to hear not just about the use of online technology, but what happens behind the scenes with the information that you're gathering and how you devise it, how you think about the ways in which we tell stories in a safe and meaningful way. I think that, you know, as a mental health researcher, any of us here can attest to the fact that sometimes the biggest challenge is convincing people why we need to evaluate something, why we're doing the research on it, or why we're teaching about it. And it's not always about making sure that we are answering all of the questions about safety, but about why we're asking people questions, why we want to hear their stories and what we can do with them. So it'd be really lovely to hear a little bit more in the question time about what you're doing with all of those component parts and what we can actually do with them, rather than research for research's sake, which is sometimes a challenge. So thanks so much. I'm just going to jump to some slides that actually conveniently, without me even planning it, fit really nicely with what Josh was talking about today. So as I said before, Anwar was going to be one of our guest speakers here today, and he's just landed in the United Arab Emirates for a conference, and sometimes the universe does not allow for everything to come together and present at the same time. Now, I am not a machine learning kind of data scientist type of person. I'm entirely qualitative, but I think over the last 15 years, and particularly in my teaching of social work students and other health students, is that I'm really starting to see the ways in which we can use online technology and AI in terms of better understanding who is out there in the community and how we can support them. I think one of the great spaces that is starting to get more and more traction is the role of online simulations for our health students, and about thinking about the ways in which we better enhance the workforce without putting anybody at risk while people are learning. So I think that there's some great ways that, irrespective of what sector you work in, you're able to take bits and pieces from this conversation. Now, Anwar's work has been around looking at the role of complex suicidal ideation detection in social media and thinking about it from a deep learning perspective in terms of machine learning. Now, a couple of years ago at the beginning of the pandemic, Miss Maple and I worked on a year-long study looking at the voices of mental health as well as suicide prevention in the community. And part of that was around media representations, including social media. Now, I've placed Anwar's contact details here because I don't anticipate that I am at all able to get to the depth of what his expertise is. So if I say something that kind of doesn't sort of make sense, then please direct all questions to Anwar, and we'll get him to look at the recording and provide some context there. But I think for many of us, when we think about suicide, we're very much immersed in the space where suicide is spoken about openly in the work that we do or the research that we do. It's always an important reminder to recognise that suicide is not spoken about openly in the broader community. Yet, the World Health Organization tells us that over 800,000 people die by suicide that we're aware of each year, making it the 17th leading cause of death globally. And as Josh was talking about in terms of those trending topics of young people engaging with the Batyr platforms, talking about the issues that are of significant concern to them, suicide is also a significant concern amongst young people. It's the second leading cause of death amongst individuals aged 15 to 29 worldwide. But we always have to remember when we provide that statistic that we also want to acknowledge the needs of people who are at risk of suicide attempt, who live with suicidal thoughts and suicidal ideation. Because when we talk about young people who are dying by suicide, we also need to recognise the overrepresentation of numbers of young people living with suicidal thoughts every day. We know that young people turn to social media as well as adults in terms of trying to make sense of their suicidal ideation. And Anwar's work has looked at the ways in which people who live with suicide attempting, and I'm very deliberate in my term of living with suicide attempting, we've evaluated a number of programs, particularly in regional New South Wales, around people that live long-term with suicide attempting and needing to challenge the ways in which we think of people having a one-off incident and then being able to recover and move on, about what that means long-term for people in their lifetime and what that means for their health and well-being. Now, Anwar's work talks about the ways in which both suicide attempting and people who die by suicide leave traces on social media. Often the significant challenge when we're providing support post-vention or in suicide bereavement is really about trying to provide support to people who are left behind, who are looking for the clues in order to think about ways that they could have changed the outcome. So when we talk about leaving traces, this is not about suggesting that everybody should have picked up on the information that was left behind, but about using that information to better enhance the ways that we provide support to people. We also need to recognise that people in regional, rural and remote communities have significant challenges in terms of accessing face-to-face services. We know in terms of an aftercare service that we've recently evaluated is that people who are discharged from hospital in regional communities often struggle to engage with unique or bespoke aftercare services so that they can really connect in with what's actually available, not what we perceive might be available. So Anwar's work looks at the detection of suicidal ideation through social media data. And this can be really helpful in terms of suicide prevention efforts, but it also comes with limitations and considerations. I know when I'm utilising Google or Google Scholar to look for information that might value add my research that I'm doing, or I'm looking for a referral network for somebody, if I type in suicide bereavement service in a particular region, my first pop-up on Google will be, it looks like you might be at risk, or it looks like you might need some care. What can we do to help? The same ways in terms of utilising social media is about understanding what those data sets might tell us about our preparedness to respond to people who do leave those traces on social media. You can see here some examples from Anwar's work, 2 different posts that he's provided some clarity with here in terms of providing us with those traces. The first one is about a recognition around the ways in which people might frame their discussions about their thoughts or their actions. It also means better understanding, utilising those data sets to value add to the knowledge base. You can see that some people will be incredibly overt in terms of talking about the ways in which they're feeling about themselves, and it might be less of an ambiguous idea about trying to understand their suicidality. We know that in the development globally of mental health resources and support, that AI is being used across the board. I think that the explosion of information that we've started to see around the use of artificial intelligence over the years has also come off the back of a lot of discussions around the pandemic, some conspiracy theories as well. That means that there's not just one conversation that's happening in the community about the benefits of AI, but more, like we've started talking about at the beginning, about recognizing the role one step back of online technologies, about working out how we can work together. So it's not either or, it's not real life interventions or online interventions, but about recognizing interventions will provide different things to different people. Now, Anwar's work talks about the role of artificial intelligence, and this has been around since the 1960s. It's not something that turned up when we started as talking about ChatGPT over a year ago, but it's about recognizing the role of automation. And I think when we talk about the mental health workforce and the significant challenges that universities and other sectors have in terms of making sure that we graduate enough people to step into those workforces, that often the conversation as well will be, well, how can we work? I always get the term backwards, smarter, not harder. Sometimes I say harder, not smarter. And to be fair, sometimes on a Thursday or a Friday, it's that way. But we need to think about the ways in which we can be creative with the technology that's available to us, where we can think about using the muscle of AI and the mind of humans and co-constructing or co-designing the ways in which we might learn from the data. Now, Anwar provides a really easy to understand explanation here about the use of AI tools and how they might allow us to incorporate them in mental health program and service delivery. He talks about the role of tools like knowledge-based systems that shape the way that these online technologies perform, how they actually work. Then also using other aspects of artificial intelligence in terms of the ways that we think about what people share online, natural language processing, the words that they use, the intonations that they use, whether or not they're positive or negative about the information that they're sharing, the certainness or the ambiguity around the ways in which they share information, how they present the knowledge to the community who might be listening online. As well as understanding from a sense perspective, how are people behaving when they're engaging with those online tools? And then how are media processing that information and then providing to the news cycle that, of course, is going to shape the way in which we live with mental health and well-being in the community, because we're going to be influenced by what the media tells us. Now, before I move over to Anna talking about the amazing work that always happens with LifeLine, is that it's always really important to recognise the fact that any use of artificial intelligence has to be responsible, that it balances privacy and prevention. that we need to think about, well, what's the outcome? What are we hoping to achieve by using these tools? From a teaching and learning perspective for our workforce, it's recognizing that if we are using certain AI tools, what are we hoping to achieve for the people that engage with the service that you're working for? If you're using it for research purposes, what are you hoping to achieve in terms of better understanding your data set? If you're devising media guidelines or thinking about the ways in which we share our knowledge, making sure that the tools that we use represent the data that we've collected. So just some almost simple reminders here in terms of thinking about the fact that we can analyze individual level data using those machine learning algorithms. And we have to think about the ways in which how we approach that data from an ethical perspective, using those anonymized data and thinking about the ways in which we can aggregate those. Thinking about how we can use that information about people who are sharing online to flag those posts and about what those predefined criteria are. We don't want to limit the storytelling online. Everything that Josh talked about with Batyr, with the pre-moderation versus the post-moderation, means that we don't want to limit people's capacities to share, particularly in our regional, rural, remote communities where there might not be the resources available like we might have in metropolitan cities. We want to make sure that any data that we collect is that a person has voluntarily said yes to the sharing of that data, so that we recognise what the privacy preferences are and that we respect that at all stages of anything that we do. And most importantly, particularly for the audience that's here today, that whatever we identify from the use of artificial intelligence is making sure that we collaborate with mental health professionals. Knowledge translation is key. Everything that we've been doing at Manor over the last couple of years is taking the evidence base, using the current technologies, and then thinking about what this means to deliver to those communities that we work on behalf of. Making sure that whatever we design is appropriately evaluated, that we understand who we're intervening for and what supports are going to be most important for them. So I guess it's not an either-or conversation in terms of online technologies, but how they can value add the work that we do as individuals and professionals. So Anna, I'll pass over to you now, and you can provide us with the last conversation before we move to some questions.
Thanks, Sarah. It's wonderful to be here. Always a pleasure to be able to support the terrific work that Manor is doing, a cause close to my heart. I think all of the work that the Institute does to bring a focus to rural, regional and remote mental health is it plays an incredibly important role nationally in terms of making sure that rural, regional and remote mental health is considered as carefully and as deeply as it should be. It's great to have Manor as part of that conversation. Today, I'm going to speak a little bit, I'll provide an overview of LifeLine services, how we leverage online technology to make sure that we're delivering service across the nation with a keen eye on improving accessibility for people no matter where they live. I'll then focus a little bit, the rest of the conversation from me on AI. I've sort of taken a high-level view about AI and its application in suicide prevention. I'll talk through a couple of points, including that trust and acceptance of AI is complicated. I'll talk through some of the points around that. I'd like to share a few cautionary tales and then point to some best practice examples when it comes to AI and suicide prevention. So starting with LifeLine, just to provide, an overview about the organisation. LifeLine has been operating for more than 60 years in Australia. We're the largest suicide prevention service provider, and our vision is of an Australia free of suicide. We have our national network comprises 18 member organisations, and those 18 member organisations run over 40 centres that are located in metropolitan regions, but also in regional communities across the nation. We deliver services to Australian people in crisis wherever they might be, whenever they're needed, and on the platform in which people are most comfortable accessing those services. So we have, I guess, a suite of different services, and I'll just give you a bit of an overview of those, noting that most people know LifeLine for our helplines, and in particular our 13 11 14 service, which is a voice-based service. And as you probably know, it's running 24 hours a day, 7 days a week, delivered by crisis supporters located across the nation, delivered largely by a volunteer workforce. And the intent with that 13 11 14 service is that it is a low barrier to access service. So we typically would say encourage people to reach out to 13 11 14 when they feel like their coping mechanisms are overwhelmed. And we communicate that 13 11 14 is a service where people can share the things that they're experiencing with someone who's highly trained, but it's a non-clinical approach. And our crisis supporters are, the extensive training they go through ensures that they engage in reflective listening, they meet people where they're at, and where appropriate, they provide onwards referrals to people. We have a chat service and a text service, both of which are now also 24 hours a day, 7 days a week. It's one example of us leveraging online technology to really make sure that we're maximising the accessibility of our services for people. In addition to our suite of helplines, of which there are more, but just sort of trying to keep it to keep to our time limit today, Sarah, we also have digital services. So a range of services, including our self-support toolkit, which is a self-guided resource for people available via our website, where people can access information and, again, referrals, depending on what it is that they're experiencing. And importantly, we're looking at ways to leverage online technology to actually make people's journey to finding that self-support toolkit easier. So we're looking at search patterns and how we can actually make sure that our self-support toolkit is a resource that pops up when people are looking for material that's related to suicidality in particular, but also a range of other things, like they might be experiencing, like the way that they express what they're experiencing might be that they don't feel like they can cope. So looking to make sure that the search terms that people use, they have a high likelihood of ending up landing on our self-support toolkit resource. In addition to those services, and much less well known, is the fact that we have a range of community services offered from the centres across the nation. Those include things like suicide bereavement support groups, the Eclipse program for people who've attempted suicide. And those services are often offered face-to-face, but we also have complementary online offerings to, again, increase accessibility for people who may, be living rural and regionally, or who may have a preference to engage in an online format. So that's a bit of an overview about LifeLine. Turning my my thoughts to AI in particular, I have shared a few resources. I'm hoping that they might be able to either be shared while I'm speaking or perhaps afterwards. But a couple of key points that I mentioned in my opening. AI, it's an area in which, I personally am interested, certainly not an expert like you, Sarah. But certainly, LifeLine, obviously, as a service provider with a goal to make sure that our accessibility is high for people across the nation, we're obviously very alive to and cognizant of the opportunities that technology provides to be able to support our service delivery, and perhaps to enhance the human-centered approach that our crisis supporters and other, other service, people delivering other types of services, to enhance that human-centered focus that all our services have. A few sort of key points for us. There was an interesting paper from KPMG and the University of Queensland last year about trust in AI. And it was like, an international study, 17 countries, at least 1,000 people from each country provided data. But some of the key take-homes from that paper were that trust in AI predicts acceptance. Sounds pretty intuitive, but it was interesting for the data to bear that out. Interestingly, in terms of the Australian sample, it's a minority of people who actually express that they believe that the benefits outweigh the risks of artificial intelligence. So in Australia, relative to other countries around the world, our trust in AI was relatively low, and that had a flow-on effect, a negative flow-on effect to acceptance levels for AI. Now, that's super important to us, to LifeLine in particular, as you know, we've got that 60-year history of being, there for people in their toughest moments. We have, as I mentioned, a low barrier access. We have a low barrier service that we provide via our helplines. We have high brand visibility, and we enjoy a high level of trust from the Australian public. So they're all things of which we're very conscious, and we take very seriously the responsibility of ensuring that we maintain that trust and continue to deliver service in a way that people find acceptable. So for us, that sort of take home from the KPMG paper is an important one. Lack of trust in AI and therefore lack of acceptance is something that we're very mindful of. And again, noting that we have a human-centered approach to how it is that we deliver service, we really want to make sure that we leverage the benefits of new technologies, but that we also ensure that we continue to provide a very human service for people. So moving on to a few cautionary tales. I'm sure we've all seen examples. Many have arisen in the mental health service provision space. It's a challenging issue, particularly in this country. You know, we've all seen the outcome of a number of inquiries and royal commissions into some of the challenges that we face nationally around creating a proper system to support people experiencing mental ill health and to support people experiencing suicidality. So I guess digital services and technology-based approaches are attractive as we try to address those challenges to make sure that we increase access to people living throughout the nation. And also to make sure that we're able to meet demand. You know, at the moment, there's high levels of demand and challenges in meeting that demand in the suicide prevention sector and more broadly. But the thing that I would venture is that whilst there's a lot of opportunity that is afforded by online technology and AI in particular, regulation, as you pointed out, Sarah, is key. Things can certainly go wrong. There's examples internationally of suicide prevention, AI, like a chatbot, providing advice that was, directly contrary to, to supporting someone through their suicidality in a positive way. Also examples from, the eating disorder space. Again, chatbots, providing advice that's actually, dangerous. So I think whilst we're aware of the potential benefits of the technology, very cautious about how we apply it. It's encouraging to note in terms of regulation that there's movement in terms of the federal government's approach. Ed Husick's office, the Federal Minister for Science and Innovation, has just established an AI expert group that will inform the government's approach to regulation in this space. So that's an encouraging development. Obviously, it's very much on everyone's radar that the potential benefits are there, but as regards AI, but that we also need to make sure regulation keeps up. In terms of best practice approaches, I think that I would point to not only sort of ensuring that regulation ensures things like transparency of the data that's been used to develop a new tool, but that also that new, approaches based on AI are tested in context. So it's incredibly important that we take an evidence-based approach and that we make sure that whatever tools are developed are actually fit for purpose. There are examples of people doing this well in the suicide prevention space. I'd point to some work from some colleagues at the University of New South Wales. who are trying to design approaches to AI tools that support people, as regards mental health and suicidality, from the ground up, using with a very keen focus on drawing from people with lived and living experience of the particular context that the tool is designed, in which the tool is designed to support people. So there are I guess, positive signs in terms of the sector's awareness of the need to use data that is well considered, that is heavily based in lived experience, and that also takes into account some of the, I guess, the risks and dangers of applying online technology, in particular AI, without considering all the key factors.
Yeah.
So I'm optimistic about what can be achieved, but again, caution is always important, and particularly for LifeLine as a human-centered service provider. We'll be making sure we measure very carefully what types of approaches we use.
Perfect. Thank you,
Sarah.
Anna. And I really love the way in which you reminded us about the fact that LifeLine is human-centered. And I think that often the conversations that we have about the development of technology is that they are for humans, and that the ways in which we design them utilize, advisory groups and things like that. But I also think from a developer perspective, it's about recognizing who those human beings are, what evidence base they're utilizing, and thinking about the ways in which they're designing the technology, that we don't just have to think about who's this for, but who is making it. So I think there's probably like 5,000 different topic areas that we could cover across. But what I'm going to do in the last 10 or 15 minutes, happy for people to stay on a little bit longer, is jump to some of the questions that are in the box already. And thank you to those who said it was a great presentation and had to move on to their next meeting, like we all seem to have to. Hayden, if I could jump to you first, happy for you